good morning, afternoon, evening, depending on where you are in this world. Thank you for joining this ATS webinar. So today we're really excited to have really a really distinguished group of speakers from all over the world talking about the 2021 WHO air quality guidelines. And so let me just go over, a few logistics. And so we're going to mute all the participants because we have over 200 people actually signed up. And so for the first hour, we'll have these 4 talks. But if you have questions, please post them in the chat and we'll monitor the chat. The last 15 minutes of this sort of webinar will be a question and answer / discussion session. And this is where we can interact with your questions. And then finally, this webinar is going to be recorded and posted on the ATS website YouTube channel. So please feel to share the link with your colleagues when you're done. All right, so I think because our time is quite limited, I put in the chat the agenda for today. But air pollution remains the leading modifiable risk factor for morbidity and mortality globally. And so we are talking today about the new WHO 2021 updated clean air quality targets. And so we have a series of 4 talks. The first one is from George Thurston, who will go over the rationale and the changes to the WHO air quality guidelines. And I'll just preface this by saying that this could be like a 1 or 2 hour talk. And so George, is picking the highlights and as well as providing some resources. And then the next 3 talks will be talking about, the challenges to implementing and achieving these air quality targets from 3 different perspectives. And so Gabriel Keller will be talking about the East African perspective. Kalpana Balakrishnan will be talking about the perspective from India. And finally, we have Stella Harding-Japena talking about the perspective from Peru. And then after this, we'll have our panel discussion and Q&A. With no further ado, let's queue up the first talk from George.
Today, I'll be talking about the rationale and the changes to the World Health Organization air quality guidelines. Now, I'll be starting out with a brief introduction to air pollution health effects, and then move on to looking at the basis for the 2021 World Health Organization air quality guidelines, and then presenting the guideline levels, as well as some good practices pollutants. And that's a new thing that they set this time versus the last time they did these guidelines in 2005. And then talk about the interim targets, realizing that most places have not met the guideline levels yet and the steps leading to them. And in this presentation, I'll be using materials that I've gathered from the World Health Organization Air Quality Guidelines report. And then also I'll be using, with attribution, the slides from a webinar that was done about a year ago when the 2021 guidelines were released. And it was done by the ERS at the time. And Zorana Anderson introduced that and talked about the statement that we made, that we developed, and it was over 100 endorsements of this statement in support of these guidelines. And so coming from this statement, we then, they then had this webinar when it was actually released to the public. And this was, again, endorsed by many organizations, including the American Thoracic Society. As we know, the air pollution around the world has been linked to millions and millions of deaths every year. And of those effects from outdoor air pollution, some of the largest effects are from long-term exposure to fine particulate matter air pollution, although other pollutants contribute. And most of those effects are, again, from cardiovascular, but then there's a wide range of effects because, we not only see deaths occurring from the air pollution, but then much larger numbers of hospital admissions, doctor's visits, asthma attacks, and a whole range of effects. And everybody is exposed, and so there are adverse effects of varying severity depending on the levels of exposure, and the susceptibility of the individual. As I mentioned, there's many diseases, not just lung disease and cardiovascular. As I said, it shows here respiratory disease, and this is from a statement that we did, American Thoracic Society and the ERS did a few years ago that I led, what constitutes an adverse effect of air pollution. And it's not just respiratory and lung cancer, but also, and cardiovascular, but also a wide range of effects throughout the body. We're learning more and more, like diabetes, high blood pressure, and premature birth, and other developmental effects on children from in utero exposures. The ones that are in the bold are the ones that were used by the Global Burden of Disease study to assess the numbers of effects of air pollution around the world, for all the countries in the world. But we know that, as I mentioned before, the levels of exposure vary, and we see that especially in Northern Africa and Southern Asia, the levels are much higher, and there's even more work to do there in getting down to the recommended levels. So what are these guidelines? And Maria Nera presented at the webinar a year ago that they're based on scientific evidence, the available evidence, and they try to define the levels of air quality necessary to protect public health. They provide recommendations on the guideline levels and as well as interim targets along the way, as I mentioned, for fine particulate matter, PM2.5, PM10, which is inhalable particles that get past the trachea, ozone, nitrogen dioxide, sulfur dioxide, and CO, carbon monoxide gases. And there are also, in addition, and I'll talk about this a bit, good practices statements for certain types of particulate matter, certain constituents that are not directly regulated specifically under the mass regulations for particulate matter. And the goal of these guidelines is that they can be used as evidence-informed references to set goals and setting perhaps legally binding standards and goals for air quality management of taking certain measures. And a metric to measure progress against. It really is thought of as a tool that countries can use and cities to design effective measures to achieve reduction of air pollution and therefore protect public health. So here are the guidelines, and I'm showing here the 2005 air quality guidelines versus the 2021 latest ones, and they're for long-term, annual, and short-term periods, such as 24 hours for PM2.5 and 8 hours for ozone. And you see that generally the levels have become more restrictive. We've got more evidence of pollution effects at lower levels than we had back in the early 2000s. So we see, like for PM2.5, it goes for the annual average from 10 down to 5. And I'll go through that as an example of how they chose that, and the 15 for 24 hours. So, looking back at 2005, there are only a few cohort studies that have been done to look at the long-term effects. One of them was the study that Arden Pope and I led that was published in JAMA in 2002. And Bert Brunnerkreef showed this slide showing that looking back at 2005, they set the 10 at a point where the confidence intervals of the relationship between the relative risk rising with concentration. And as you can see, the confidence bands got wider. Why did they get wider down there? Well, because fewer people lived at those levels in the United States at that time. And what's happened over the last couple of decades is that the Clean Air Act has worked very effectively to lower exposures, and we've got more and more people living down at the lower levels, so we're able to study that. And there are lots of new studies that have come out looking down at those lower levels and allowing them to use these studies in setting the guidelines. So Bert Brunnerkreef showed the steps, but the main thing was they used systematic reviews of multiple studies. And then they looked at the lowest level of exposure where they could say it's significantly different from zero effect. And that was that they judged at the 5th percentile of the exposures at these low level studies. So they set the air quality guideline at that 5th percentile. So here's, again, some example of the studies that were used. And you see that the 5th percentile ranged from 3 all the way up to 7.8. And based on this range of low-level PM 2.5 studies, they selected 5 microgram as the limit. And then they derived the short-term study based really on the long-term, the short-term standard based on the long-term standard. And what they did was they looked at the range of concentrations in the studies, and they took the average concentration in these time series studies and then looked at the 99th percentile. So they looked at the ratio of the 99th percentile relative to the mean. What's the ratio? And they primarily used this 652 multi-city study that was published in the New England Journal of Medicine, and the ratio came out about 3. So they said, well, okay, if that's the ratio in the short-term studies, then the equivalent would be 3 times 5 or 15. That's where they got the 5. So they had this approach and they applied this to all the pollutants and by analogy. They also set interim targets, as I mentioned, and good practice for some PM constituents. And you see here for each of the pollutants and their averaging time, the interim targets, and so that places could use these as goals to get here and set up approaches for attaining that first, and then work on the next level, rather than trying to shoot for the moon and go right to the air quality guideline level. So it's a step-by-step process where they can different jurisdictions can use different methods to get there. And as I say, the good practice statements, and here that Maria Niera mentioned in her slide, were for certain types of particulate matter for which evidence is insufficient to derive quantitative air quality guideline levels, but evidence supported, suggested that they are very toxic, related to very toxic components. And as the report says, PM 2.5 as the mass as a control metric could mean that targets could be met with no specific pressure to reduce primary combustion particles and known toxic constituents. So they selected elemental carbon, ultrafine particles, and then sand and dust storms as categories. And they discussed the things that jurisdictions should be doing in terms of monitoring and looking at management without setting a specific guideline. They set basically guidance to try and measure and assess and control these constituents of the mass. Now, we found that this is consistent with what we found in the past. And I know that when I did the first study that related mortality with fine particulate matter in 1987, we didn't call it PM 2.5 yet. We called it fine particulate matter, but it was the same thing. And we found that association with the fine particulate matter was much stronger than the larger particles in the IP10 and the TSP, which was commonly measured then, total suspended particulate matter. And at the same time, in that same publication, we did do source apportionment and say, look, some of the components are much more strongly related, especially the coal combustion particles were dominating the effects in the US at that time in the 1980s. And we've continued to find this evidence. And for example, we have a recent study that I worked with one of my students, and most of us, Raman, and he found, looking in Bangladesh, that the biomass burning particles doing a source apportionment found that they dominated the mass, but it was the fossil fuel related, combustion related particles that dominated the mortality. In fact, you can see this red line is much steeper for the fossil fuel combustion than for the biomass. As the pollution goes up, the risks go up for both of them, but it's much steeper and very statistically significant for the fossil fuel particles. So we've known about this, and so these good practices measures that they're recommending are a first attempt to try and move beyond PM mass and into the more toxic constituents. So the recommended steps, again, Maria Nera summarized these and said, that these air quality guidelines can be used as a tool to guide, drive, and support the selection and adoption of measures to reduce exposures by setting goals and ways to get there, and also give guidance for localities and nations to update or for the first time set legally binding air quality standards. And then also as a way of standardizing and therefore strengthening multi-sectoral cooperation at the national, regional, international. In other words, they've all got these guidelines, they all know where they're headed, so they can work together to try and work towards them. And then also at the same time, taking action can be aimed at reducing health inequalities related to air pollution exposures and health effects. And, she noted that the health sector, many of whom, are in this meeting, are crucial. The health sector is crucial in raising awareness and gathering evidence and advising people about how to mitigate impacts and joining advocacy efforts to bring science to the discussion. And so in conclusion, the adverse health effects of air pollution are severe and global. These new World Health Organization air quality guidelines and targets provide shared goals that can be worked towards to attain healthy air. The pathways to attainment and maximizing the clean air benefits will vary, of course, from nation to nation, but they're all heading towards the same goal. And then finally, I just add something that I think we always have to think about is how does this relate to climate change? And in fact, the actions to meet these clean air goals will also reduce emissions of climate change air pollutants, notably carbon dioxide, especially if these clean air efforts focus on reductions in fossil fuel combustion sources. So thank you very much.
Hello everyone, my name is Gabriel Okello, Prince of Wales Global Sustainability Fellow in Air Quality and Non-Communicable Diseases at the Institute for Sustainability Leadership at the University of Cambridge. I'm also the co-founder of the African Center for Clean Air. Today, I'm glad to share with you on how we can work together towards meeting air quality guidelines in resource-limited settings like the East African region. A little bit about the African Center for Clean Air. It's a research center that is working with regional, local, and international actors to co-design strategies to tackle air pollution and provide evidence for policy changes to protect health. A little bit of highlights have been the Measuring Air Quality for Advocacy in Africa project, a project that took place in 8 countries and 15 locations on the African continent. Also, another highlight has been the second-hand smoke training in Ghana, and also the input to the WHO guidelines, the current WHO guidelines. Another highlight of the ACCA has been collaborating with policymakers, including the Ministry of Energy, to co-design strategies to address the household energy transition. A little bit of overview on air pollution in the region. I'll first give a highlight of what is happening in the region. The countries in the East African region are undergoing rapid economic development and industrialization, and this has been associated with the increase in air pollution levels, especially outdoor air pollution levels. Air pollution on the continent is responsible for over 1.1 million deaths every year, and it's also placing a huge burden on the already overstretched public health systems, and is damaging the economy. When people are sick, they miss work, they miss going to school, there is a decrease in productivity. So all that is really affecting the region and the ecosystem. A little bit more about the current levels of air pollution in the region. You know, as I earlier mentioned, East African region is experiencing high levels of air pollution from the available data. The levels of one of the pollutants, PM 2.5, from the recently concluded project shows that the levels range between 25 and 80 micrograms per cubic meter across different locations, and this exceeds the recommended annual levels for PM 2.5 from the WHO, and also exceeds the mean daily averages recommended by the WHO. I just provided a snapshot for some of the locations in Kampala and in Nairobi. These are averages over 12 months. You have Kampala having averages over 9 times the recommended WHO levels, and Nairobi you have averages equal to 5 times the recommended WHO guidance limit for particulate matter PM 2.5. The figures on the right-hand side show the levels across the day for the whole year in both locations. More data from the ASAP group from the University of Birmingham also showed that the daily averages were 2 times to 3 times the recommended WHO daily limits for fine particulates 2.5 in Addis Ababa, Kampala, and Nairobi. So a bit of insights about the major sources of emissions. In those, we have solid biomass fuels, including firewood, charcoal, and crop residues that are mainly used for cooking. We also have lighting sources like the hurricane lamp and the lantern. For the major sources outdoors, we have rubbish burning from the various dustbins. People burn this rubbish to get rid of it, hence causing a lot of ambient air pollution. We have the industries that are mushrooming in different locations. They're also causing a lot of outdoor air pollution. The cooking itself, the street food, is contributing to the ambient air pollution, and also motorized transport, the public cars, the private cars, and the motorcycles that have really increased in numbers in various locations in the region. What are some of the challenges in trying to achieve the targets? Specifically for the region, there is limited data on air pollution monitoring. In fact, most of the monitoring is taking place in urban areas, and is taking place in localized localized areas, and it's not spread throughout the whole country. So there is limited data, hence affecting the evidence to try and come up with strategies to address air quality. There's also, in areas where the monitoring is taking place, there's limited capacity to interpret the air pollution data, especially among the communities and the policymakers. So this is affecting the data to be embedded into the different policies. If the policymakers can't interpret it, then they can't integrate it into the various policies. There is also limited strategies on tackling air pollution in the different areas. For example, in areas where there's a lot of burning of biomass for cooking, there are limited strategies in terms of the cleaner burning fuels. Either the available ones are not affordable, or they are not easily available in the local communities, so making it difficult in trying to achieve these targets. There's also low public awareness on air pollution and its effects. Hence, this is affecting the demand, the advocacy from the communities themselves to try and demand for clean air. Another challenge has been, low political commitment, but I must emphasize that this has changed over the past 18 months. Governments, policy actors in the region have really gotten engaged with the discourse on air pollution and how to tackle air pollution. So this, much as it has been a challenge in the past, it has changed in the recent 18 months. So, which leads to the next challenge, which is now the limited coordination, because now the policymakers are engaged. They want to be engaged in addressing air quality, but there's limited coordination within the different countries among the policymakers and among the various actors in order to try and harness this evidence and co-design strategies. That said, there are initiatives that are currently being implemented in the region to try and address air pollution. And those initiatives, I'll break them down to 4 major areas. One, which is household energy. There's been policy and regulation to increase the uptake of renewable energies and cleaner burning fuels. Uganda is offering subsidies for LPG. There have been initiatives in Kenya. There are initiatives in Rwanda and other East African countries to try and increase the uptake of renewable energies. Other initiatives are currently going on within the mobility sector, where there's transition to electric mobility in buses and motorcycles in the East African countries. Though this is a relatively new initiative in most of the countries, but nonetheless, it's taking traction slowly by slowly. There's been installation of charging infrastructure in some of the cities, which we hope is going to attract the adoption of the initiatives. One other thing which is key to note is the current increase of non-motorized infrastructure. The new constructed roads at least are having provisions, especially the roads in the cities are having provisions for walking, others cycling, which is a good thing to try and encourage non-motorized transport. There's also an initiative in Uganda where certain section of the city was turned into a non-motorized space, which is good to try and encourage non-motorized transport. Another section I'll talk about is with the air quality standards. I know I've participated in the drafting of the East African air quality standards. So I think this is a good initiative. Some countries already have air quality standards, whereas others it's still in draft stage. It's still a step in the positive direction. So I think this is a major step, as it will not only help in trying to guide people on the different air qualities, on the different limits of of various pollutants, but it also help in trying to enforce these limits. Another section where there's really been a push in initiatives has been in the air quality monitoring, which has led to amplified discourse on air pollution and building of capacity. There's been a proliferation of low-cost monitors and different initiatives through the monitoring. For example, we have AirCo in Uganda, we have Census Africa in Kenya, and these are expanding in different countries. The air quality monitoring has also created awareness in some of the areas and has also catalyzed the training of policymakers and the community in trying to understand the data, but two, trying to identify the major sources within the various locations. These are some of the examples of the initiatives I've been talking about. One sector is the household energy. You can see the ethanol, LPG, improved cook stoves. Within the mobility sector, there's electric bus, electric motorcycles, air quality standards. There's a snapshot of the draft East African standard. There's been creating awareness through various avenues, for example, the Air Quality Awareness Week, and also the different initiatives that are involved in trying to provide air quality data to the public, that is AirCo and Census Africa. Next, I'll discuss on how we can work towards meeting air quality guidelines in resource-limited settings. I think first and foremost, we have to be intentional and take a collaborative approach that is centered on the involvement of various actors in policy, business, and academia to co-design these strategies. The collaboration will help us in try and leverage the limited resources. Then we can move on to financing the initiatives and the technologies that are trying to tackle air quality. We can move on to implementing the policies and regulations in form of tax waivers, subsidies, and tightening restrictions on emission sources. We can also go ahead and build capacity and skills around air quality data, around initiatives that are trying to tackle air quality. And then another important aspect that we ought not to forget is continuous monitoring and looking towards continuous improvement, identify the gaps, and then fix the gaps to try and continuously tackle this evolving challenge called air pollution within the region. I thank you very much and looking forward to your feedback, looking forward to your questions. Thank you very much.
Good morning to the organizers and attendees of this special ATS webinar devoted to sharing regional perspectives on the challenge of achieving clean air in the light of the evidence that formed the basis of the new WHO air quality guidelines. All of us recognize now that air pollution is one of the greatest killers of our age, and perhaps nowhere is this a greater everyday reality than in India. Household air pollution attributable to dirty cooked fuels and ambient air pollution attributable to a multiplicity of sources such as coal use, vehicles, agricultural waste burning, brick kilns coexist in India, creating health-damaging exposures that are often seamless across rural-urban boundaries. The ubiquity of point and non-point sources, as illustrated by these pictures, in close proximity to densely populated communities, creates a continuum of exposures over space and time, and across all population subgroups, including the most vulnerable. Just to recap the recommendations of the WHO Air Quality Guidelines, the part that is most relevant for India are the interim target guidelines that can enable the government to gradually achieve health-based guideline values through increased focus on cleaner energy technologies, in particular for power, transportation, and the residential sectors. Over the next 10 minutes or so, let me share some contextual details from India to illustrate the challenges, but also the opportunities that can be utilized to be on this trajectory towards achieving the WHO interim target guidelines and eventually the air quality guidelines. We now have a good understanding of the scale and gradients in exposures across the country. In 2019 and in many previous years, the annual population-weighted mean exposure to ambient PM 2.5 has been estimated to be around 60 to 90 micrograms per meter cube, well in excess of the Indian national standard of an annual mean of 40 micrograms per meter cube, and in considerable excess of the WHO air quality guidelines pretty much throughout the country. Much of the routine air quality surveillance and actions, however, are concentrated in large cities in India, but India is home to some of the most polluted cities where levels of pollutants is often 10 to 20-fold higher than WHO air quality guidelines. Limiting our attention to mega cities would already leave the hundreds of millions in other cities behind. Further, the population relying on solid fuels is decreasing but continues to be high. The pictures that you see here are older file pictures, but the reality of this exposure situation continues to be daunting. With 40% of India's population continuing to rely on solid fuels, that is still a major source of household exposures for some 500 plus million people. And now we have an increasing pool of studies that show household emissions to be contributing anywhere between 30 to 50% of ambient air concentrations. While the national LPG program, termed the Pradhan Mantri Ujjwala Yojana, as of April 2021, provided greater than 80 million households with new low-cost gas connections, and now 95% of households in India actually have access to LPG, largely in part due to this program. There is a further nuance in exposure disparities. There are not only differences in the proportion across states in solid fuel use as their primary source of fuel, but also in the levels of stacking clean fuels with dirty fuels. The program has provided subsidized access to clean gas or LPG, but transitioning to exclusive LPG use would require considerable additional resources in terms of more widespread subsidies and greater improvements in distribution and delivery in states that lag behind. Consequently, the health burden from exposures to air pollution is very large, with some 1.67 million deaths attributable to air pollution in 2019, and nearly equal contributions from both ambient PM 2.5 and household air pollution, rivaling the burden attributable to the biggest public health villain that our community has known, that of cigarette smoking. Given this daunting reality, where are we headed in India? India has some of the most ambitious set of clean air actions defined in the most recent National Clean Air Program launched in 2018. The sectoral controls address targets for all major sources, including transport, power, with a special emphasis on phasing out coal, agricultural waste burning, and biomass cooked fuels. You will notice that unlike clean air programs in other settings, there is a special emphasis on sources that impact rural indoor and ambient air quality, and through short or medium range transport, the entire airshed. In India, health is treated as a state subject, but we couldn't possibly approach air pollution as a state subject. Air pollution clearly does not respect these administrative boundaries, and thus air quality management efforts have to be regionally focused on the entire airshed, where health impacts of downstream populations at risk of exposures has to be captured in cost-benefit analysis and mitigation efforts directed at appropriate sources in each airshed. As part of the NCAP, or the National Clean Air Program, and recognizing the importance of surveillance, we have increased ground ambient air quality monitoring considerably. And in a remarkable achievement, the Central Pollution Control Board the primary regulatory agency in India, is also utilizing other modeling approaches based on satellite data that has been ground truthed by ground monitors to provide spatio-temporally resolved PM2.5 data that will be publicly available on their portal. This increased surveillance has importantly allowed the prioritization of sources on the basis of health impacts. In India, solid fuel use is now shown to be the second largest contributor to ambient air pollution. There have been 7 published studies to date that model the proportion of ambient PM2.5 in India and the attributable burden, and estimated to be in the range of 22 to 50% and significantly higher than contributions from transportation, power, and the industry sectors. This is, of course, in addition to substantial risks that households experience directly from cooking. Thus, what would be strategic is to pitch the mitigation of household fuel sources as a win-win for both reducing household and ambient air pollution. Shown here are results from a recent study that show that the Indian National Ambient Air Quality Standard to be completely achievable by mitigating emissions from household cook fuels and thus eliminating solid cook fuel use would be the lowest hanging fruit for achieving the Indian National Ambient Air Quality Standards. And this would already set us up to meet the interim target guideline 3 of the WHO Air Quality Guidelines. Leveraging on research evidence from strategic epidemiological studies concerning household air pollution and child and adult outcomes that are underway globally could provide some powerful risk communication tools. One such important ongoing effort is the multi-country Household Air Pollution Intervention Network trial, or the HAPPEN trial, that includes India as one of the sites. Preliminary results indicate that intervention with LPG achieved large and sustained reductions in household air pollution, with nearly 70% of the measurements of fine particulate matter in intervention households remaining well below the WHO annual interim target guideline of 35 micrograms per meter cube during the course of pregnancy and beyond. While the results of the trial on health outcomes are awaited, the initial results on intervention adoption and exposure reduction provide some of the most encouraging news regarding interventions to reduce household air pollution. Finally, if efforts to reduce air pollution have to be simultaneously matched with efforts to improve other critical risk factors included in indicators of multidimensional poverty, such as water and sanitation, immunization coverage, access to healthcare, the expected health gains or the expected gains in health can be substantially greater. 80% of the poorest globally and in India are younger than 40 years, live in rural areas, and experience 5 or more deprivations as per the Global Multidimensional Poverty Index. These deprivations not only impact maternal and child health, but have enormous implications for adult non-communicable diseases and injuries, including respiratory and cardiovascular diseases. An unprecedented opportunity may exist in India to leverage synergies in available policies. India has launched programs focused on clean water and sanitation, or the Swachh Bharat mission, clean household energy, or the Pradhan Mantri Ujjwala mission, and the childhood immunization and increased access to antenatal care, or the mission Indradhanush, in multiple districts. Piggybacking health and exposure surveillance on these programs may provide an opportunity to mount persuasive accountability studies for air pollution alongside other risk factors for maternal and child health, as well as NCDs. In conclusion, the mission of providing clean, healthy breathing spaces in India, while not easy, is not impossible. What the WHO air quality guidelines provide is the best possible ammunition to make the implementation of such a mission a near-term reality. But this ammunition has to be applied strategically and imminently. Professional clinical societies, such as the American Thoracic Society, can provide a powerful voice for health professionals to advocate the cause of air pollution for vulnerable communities everywhere. And this webinar is an important step in that direction. Thank you.
Hi, everybody. Good morning. My name is Stella Hartinger. I'm the director for Center Clima, a Center for Climate Change and Health out of the Universidad Peruana Cayetano Heredia. So the talk is, how can we work towards meeting WHO air quality guidelines in resource-limited settings? And I will just give an example that is coming from Peru. So let's put a little bit into context about the ambient and household air pollution in Peru. Of course, it's no surprise that air pollution is a priority for Peru, since it's one of the biggest environmental risk factors worldwide. What we see in Peru is that fossil fuels have consistently been the main contributor to PM2.5's air pollution, and it's causing that more than 83% of the cities exceed the safe concentrations recommended by WHO in South American cities. Lima is not the exception. Lima is a megacity with more than 10 million inhabitants, and one of the biggest shortcomings is we have very little monitoring data on PM2.5 outside of Lima, so this talk will really concentrate on the aspect of Lima. What we're seeing also is that there is a proportion of people that are that we can attribute now to be dying because of PM2.5 exposure. The Lancet Countdown on Health and Climate Change has estimated by 2019 that we have 145 deaths per million that can be attributed to ambient air pollution. Most of those deaths are linked to transportation and the domestic sectors. So what does it look like with respect to mobile sources such as on-road vehicles? We see that both public and private transportation systems rely on fossil fuels. 84% of the vehicle fleet for Lima are cars and station wagons, and out of these, around 45% are formal or informal taxi drivers. And they are responsible for around 31% of all public transportation trips. However, the most common source of transportation corresponds to buses or combis, is a picture above, or mototaxis, these little tutu bikes that we see. They are responsible for 60% of the total number of trips that we make in a day as part of the public transfer. We have the most number of taxis in Latin America, and we make more trips than any other city in Latin America per day. Another big concern is the age of the fleet. The average age of vehicles for public transportation, for taxis, it's around 12 years. And for buses or combis, it's around 14 years. Regarding the industry, the predominant items correspond to chemical, smelting, brick-making activities, and they're mostly concentrated in the east areas of the city. However, the availability of information regarding industrial activities is very limited. We still don't have new estimations of emissions and how much those emissions contribute to PM2.5. For Lima, the latest data we have was from 2006. These have not been updated. But we know that despite the limited information, we know that the plants that contribute the most to PM2.5 and PM10 in that matter is fish flower plants and zinc refinery plants. Regarding the data, the air quality of Lima, data from the National Meteorological and Hydrological Services indicate annual PM2.5 concentrations of 31.8 micrograms per meter cube in Lima for 2009. All the districts exceed the WHO standards for ambient PM2.5, and 7 also exceed the Peruvian standards of 25 micrograms per meter cube. As you see in the map above, the eastern part has the highest concentrations, many times reaching above 40 micrograms per meter cube. So this is one of the biggest problems that we have. So the key to good environmental governance and management starts with accurate data and access to data. This is how the Peruvian monitoring system looks today, and it's quite deficient. CENAMI, the National Service for Meteorology and Hydrology for Peru, the official numbers that come from this service, from CENAMI. And as you can see, we only have 8 monitors, and they're all located in the city of Lima. There are other low-cost monitors initiatives that have been happening by local municipalities or research groups that were interested in installing them. And we have the ones installed by the municipality of Lima, Colcaida, and other 2 municipalities. Then we have Purple Air, and they have IQ Air. We know that air quality is not the same everywhere. So we actually do need a good open access air quality management systems with predictive and modeling capacities. We need to expand our current monitoring system, and we know that it takes time. So in the meantime, what we should do is integrate the information that we do have in an interactive map that can show real-time estimates for PM 2.5, even if we're using low-cost monitors. This on its turn will lead to additional benefits because we can start talking about integrating air pollution monitoring and health, and this can help create a build climate resilient health systems. With more reliable information, we can help policymakers design and develop emission and control strategy more efficient. And of course, through research or researchers, we can also help develop atmospheric models that combine remote sensing and monitoring data for PM 2.5. But the only way to really reduce ambient air pollution is through healthy and sustainable transport. Again, and I will repeat this again, fossil fuels dominate transportation right now in Peru. And despite mitigation strategies such as increasing stringent vehicle regulations and increased provision of cycling lanes, we continue to rely heavily on fossil fuels, and we see no improvement in the city of Lima's air quality. In fact, we have seen an increase from 2014 to 2019. Regarding household air pollution, exposure to household air pollution from pollutant solid fuels, biomass, charcoals, dung, which is really common in the Andes, has a significant impact on public health. But globally, we are seeing that improved access to cleaner household fuels and technologies can lead to a decrease in mortality in indoor air pollution. For Latin American context, South American context, since the 2000s, the data is showing that we have an upward trend. In 2020, 91% of South American population relies primarily on clean fuels and technology for cooking. This is an increase of 15% from the early 2000s. However, despite access to clean fuels, 33% of South America's rural population continue to use biomass and fossil fuels for cooking. For Peru, this number is even higher. Peru is one of the countries with the lowest coverage of clean fuels in rural areas of the region. Currently, only 42% of rural households in Peru use clean fuels for cooking. And of those, it is reported that 20% of those households continue to use biomass fuels as a secondary fuel source. So stove stacking is actually happening. Depending on the fuel type that these families are using, the exposure to PM 2.5 varies. We find that rural households have an average of 170 micrograms per meter cube, exceeding the WHO standards. However, there are some studies in other areas where households only use dung, and they're seeing average values of 1,200 micrograms per meter cube. So there's much more pollution in those households. As I was saying, there is an increase clean cooking fuels and technologies for the past 20 years. For Peru specifically, this could be because of 2 big programs that we have. In 2009, we had a very big improved cook stove intervention program led by the government that it was called Have a Million Improved Cook Stoves for a Smokeless Peru, in which NGOs, national programs were encouraged to install improved cook stoves in the rural settings of specifically the Andes. The second program that had a very big impact is the Social Energy Inclusion Fund called FICE. And what it basically does, it subsidizes an amount of the LPG tank. So just going back to what we found when we did the research on the impact of improved cook stoves in rural Andean communities. What we saw in this study is that despite that there was a modest reduction in personal exposure to PM 2.5, as we see here, we were not reaching the WHO standards for indoor air pollution. But not only that, this really opened a huge discussion about what does exclusive use, adoption, or only use of an improved cook stove device actually looked like. So what we saw in our study is that only households that stoves were functioning at a very good level had those reductions. If this household's chimneys were clogged or there was a leak somewhere in the structure of the stove, even the exposure or the amount of PM 2.5 could be higher than a regular open fire or other type of traditional cook stoves that they were using. And the biggest setback is that still the chimney is using or eliminating some of that smoke, but families are now gathering in the household environment, the kitchen, because the ozone particulates, the big ones, were actually being emitted through the chimney, but the more dangerous ones were still there. So this change in behavior is something that led us to do the second study in what does it actually take to adopt clean cook stoves. And we found many enablers, and many barriers for ICS adoption, especially for Peru. So the main barriers is that we can't see the system of adoption as static. It's completely dynamic, and it really depends on who you ask or where you work. For example, in the interpersonal level, how the people actually view this technology, one of the biggest things is design and durability, reduce cooking times, reduce wood collection. And those are the most important things to actually uptake it in the beginning. But then other components start appearing that makes the improved cook stoves adoption so difficult. So if we look at the community level, we had to start creating competences. There has to be some level of capacity so that we could actually repair the stoves once they broke. And since they were done in materials you can actually find in the area, the stoves actually broke quite quickly. Making the space for markets and repairs super important. The next barrier that we actually did find is it was an institutional level barrier, and it's most of the stove programs were targeting specific people with specific characteristics, small children living below the poverty line or extreme poverty, and this exclusion criteria in the communities gave sense to unfairness or favoritism, which again led to aspects of the interpersonal with your neighbors to tarnish sometimes the reputation of these NGOs or these programs that were coming because they were not receiving the same benefit. So there were many barriers that we actually saw with the ICS uptake and adoption that we continue to see. Regarding FICE, the LPG stoves and how they work, there was a study done in Puno called the CHAP study that gave LPG gas stoves to adults in an effort to reduce the cardiopulmonary outcomes. I'm only going to talk about the exposures. So what we actually see is that the baseline, both groups actually look quite similar, with the PM 2.5 averages almost reaching 1,000 micrograms per meter cube. This population relies on dung for cooking. And we see that after 3 months, 6 months, 12 months in both groups, in the kitchen environment and the personal, there was a massive reduction of PM 2.5. The big issue with LPG interventions is sustainability. Why do I say this? In another study that this group did the same thing, they actually did an assessment of how this program was working. And what they found is that, yes, it's correct, there is an increase in LPG use, but there's an increase of LPG use plus an additional fuel. And this additional fuel is dung in this opportunity or wood. What we see in the graph on the panel of my right is that the exclusive LPG use in rural communities, it's still quite low, only around or below 10% continue to using. This leads us to the other interaction that is stove stacking. And this stove stacking is happening because there is a very big barrier, and it's the monthly cost of the LPG tank that many times is more than rural households can afford. So I'm not saying that the outreach of the program is not working. The outreach is actually working, but the high prices and the availability still remains a big barrier in the setting. And it's reflected really on the number of people with clean cooking and technologies in rural Peru. So should we change a strategy to make clean energies more accessible? A recent Lancet report is showing that 98% of all South American countries have access to electricity. So maybe we can actually also shift to electricity as an alternative source for cooking. Before I leave you, I just want to leave you with two conclusions. For ambient air pollution, the transition to public transport fleet of ultra-low emission vehicles and well-designed, energy-efficient and clean fuels for public transportations must be prioritized and accelerated to reduce or to improve air quality. And for household air pollution, we must find efficient and effective clean energy matrices for cooking and heating throughout the country. This must come with the economic provision, and there must be regulatory incentives to actually do this. We know that switching to clean fuels can greatly reduce exposure to household air pollution and diminish urban and rural inequalities. And that's what we're saying. So thank you very much for your attention, and I'll leave it there.
All right, great. Thanks, everyone. That was really an incredible series of talks. You know, it's striking to me that, you know, there are some common challenges like lack of monitoring, especially outside of the urban setting, but also, you know, sort of shared ideas for how to improve access to clean air. So now we have about 10 to 15 minutes for a panel discussion. Maybe I'll just start with the first question, which is, and this is particularly for all the speakers, is how have the 2021 updated WHO air quality targets helped or not helped in your ability to advocate for clean air? Because, you know, what is pretty obvious is that, you know, in all of these contexts, you know, even the prior targets could not be reached. And so maybe I'll just open it up. Maybe I'll have Stella start first.
Sure. So I think that the new targets are just bringing more challenges to what we have at the time. So I don't think that we are capable, as we are right now in Peru, to actually meet them regarding ambient air pollution and not even indoor air in specific areas. So what I do think is that we need to bring awareness to our policymakers, and I am not quite sure if this is actually happening. So for us in Peru, we're working a lot on bringing awareness on climate change. What are the benefits of mitigation strategies and the links to health co-benefits, so that we can actually get the discussion going in that way, so that we can get the Ministry of Health to be more involved, so we can get that our national adaptation plans consider health, because at the time being, very few of them do. And I think if we bring awareness maybe in that way, and really show that trap interventions will reduce emissions, will reduce PM 2.5, and it will bring health benefits, I think that's how we should approach the discussion, at least for us in Peru, because climate change is a hot topic right now. And I think we need to build, how do you say, like go into that, to stay, get into that wagon. I don't know how to say it in English, but just to go there, no? And try to push it that way.
Thank you, Stella. How about you, Gabriel, for East Africa? Have these new air quality guidelines been helpful or discouraging?
Well, I think it's
it's a mixed bag depending on who you're talking to. For me personally, when we're in the discussions with the policymakers and other stakeholders, the thing that I usually try to put forward is that at the end of the day, we know there are no known safe levels. So even even the current ones, much as they are recommended, there are no known safe levels. So it's important to to have a plan and get a direction, set milestones. For me, I think achieving these standards is more of a marathon than a sprint. So
Yeah.
or else they're just going to get discouraged that you can't make them, you can't keep making them, and you keep failing, and it just discourages anyone. So the approach, at least we've taken, is to try and set the interim targets. The draft guidelines, at least for East Africa and Uganda, I think are not yet released. They still have to go through parliamentary approvals. But if you see the limits that we've put are slightly higher than the WHO. I had it higher than the WHO limit, and to me, it's not a bad thing per se. It's just having that transition. It might take 1 year, it might take 5 years, it might take 7 years in the different local context. So it's very important to think about the steps of the journey, to look at the gaps within the local context, and to look at local contextual solutions, and not get so worked up about the actual WHO number, as long as you're heading into the right direction. I think that is more. I've seen that in some places where they've discouraged rubbish burning in the communities, and there are less there are less asthma visits, etc. So I think it's more of a journey than a sprint.
Thank you, Gabriel. What about you, Kalpana? I mean, the programs you outlined for India are really just, it seems to be quite ambitious, but also there seems to be a lot of support. Are the new targets helpful for advocacy or not helpful?
Yeah, I would say that, more than the issue of the numerical values per se, the whole process has been extremely helpful, because what it did was, at least for many of us who have been sort of on both sides, informing the evidence pool for WHO as the guidelines were getting set up, and also sort of looking at the national standards or the revisions proposed thereof. One of the things that has changed between 2006 and now is inclusion of a large number of studies from Asia, and it's a much bigger exposure range that we have been able to sort of include in the evidence pool. So in that sense, the skepticism surrounding the shape of the exposure response, is reducing. And that's an important thing, because back when we did this in 2006, I'm sure George and I were part of the earlier process too. This challenge of not having sufficient evidence at the higher end of the spectrum was extremely acute for PM2.5, because there was virtually no monitoring whatsoever, even possible in 2006 for PM2.5 in many of the Asian countries. So now that we have a very good PM2.5 monitoring network set up in the country, and the fact that the revisiting of the evidence did not change the interim target guidelines, or at least the highest of them put forth, is a big step, because then, you have to get lower and lower, but at least that benefits of getting to the 35 micrograms, the evidence has not sort of changed our thought process on that. So that's a very, very, important first step that we can all feel comfortable in, that
15 years later, we took stock of a much greater pool of evidence. This is even stronger than before, that we need to be moving, as you know, as Gabrielle notes and as Stella notes. We know some sources in our low resource setting. That is the lowest hanging fruit for ambient air quality, for household air pollution, for climate, for clean energy, for energy equity. And to me, especially after listening to all the three talks, you know, I've known of all the work of all these colleagues, but this is a perfect reinforcement that we should be looking at a source that can all get us down that trajectory, and that's household sources. I agree with George that we don't know enough about the toxicity and the shape of the exposure response, but I don't think there's anybody in the room who wants to argue that we need to be looking at doing away with sources that contribute a great deal to ambient PM 2.5. And in low resource settings, without fail, if there's one source, that's the household source. It is ambient. So if we can sort of really looking at concessions, so I would say guidelines are super helpful, and given that they've been done after 15 years, it was already overdue, and if we had waited longer, they would not have reinforced. But the key is, as I think Stella noted in our last slide, you know, how do you come up with these matrices of interventions for urban sources versus rural sources or national sources that sort of factor in the economic assistance that is required for us to achieve that would be key. Sorry for that long response, but thank you so much.
Thank you, Kalpana, that was perfect. George, do you have a comment on this question?
Well, yes. Yeah, from the U.S. point of view, I just say these are very helpful because we're right now reviewing, you know, the administrator is reviewing the standards, and, you know, these goals are achievable in the U.S. I mean, we could do this. What's lacking, you know, we have the resources, we have the technology, and the only thing lacking is political will. And so I think that what this guideline does is it bolsters the argument that we need to set more stringent standards. And, you know, in the process of meeting these, as I alluded to, you know, the things that California is doing right now, switching over to electric cars, getting off of fossil fuel, these things, you know, they are for air quality, make people healthier, but at the same time, we're getting there in terms of climate reduction in climate emissions. And, you know, to pick up on what Stella said, electrification, you know, I see that as, you know, if we can switch over to getting people cooking with more electricity, then, and then, you know, you centralize the problem to power plants and energy supply. And if you can, you know, centralize the problem, then you can control the pollution at those central places. So that's an avenue that I think is an important one at, you know, in every country, whether it's the developing world or developed or wherever, by making the problem more controllable and centralized.
Great, thanks, George. Do the panelists have questions that they want to raise for the whole group? Or I have several others, but I don't want to monopolize the conversation. And we're also looking in the chat to see if the audience has questions too. Another question I had was, you know, how can the American Thoracic Society or ATS members help in this initiative to achieve cleaner air, whether this is through research, you know, clinical care, advocacy, etc. I know this is a topic, particularly for trainees, actually, they're very passionate and you know, interested, but they don't know what would be beneficial or how they can help.
Can I chime in? Yeah, I think you know, the ATS has a huge presence in South Asia amongst the respiratory physicians and the cardiovascular physicians for everything, and increasingly so for air pollution too. But not, you know, I would say that the regional chapters attention on risk factors outside of smoking is fairly limited. And I think we could do more. We can sort of make this the heart of the discussion, at least for regional meetings. So, for example, in India, in the ATS co-hosts with the Indian Chest Society, the National Pulmonology Conference. And usually, air pollution sort of, gets a minor 10 minutes or 15 minutes to sort of really talk about the issue and have the clinicians convinced. And I think having a bigger pool of clinician researchers who have been part of the air quality guidelines, who have been part of the air quality standards in other parts of the world, the evidence synthesis, the whole works in these sessions can sort of really play a bigger role in sensitizing the clinician community. And then the clinician community usually, at least in these settings, does sort of very high level statements. Air pollution is damaging to health kind of thing. I think we need the clinician community to be much more engaged in the reviewing the evidence and sort of, looking at where we can sort of strengthen the evidence in our own setting and sort of be more convinced about it, not just do somewhat of a lip service to sort of, endorse the whole point. So I think ATS community of physicians who are sort of really engaged in this can really, really help increase the level of conviction amongst clinician communities in our settings.
If I can go next, I agree 100% with Kalpana. I think that communication strategies, how to engage with other medical organizations from our countries, for example, will be very beneficial. We try to do at the Lancet, when we do the launches, we actually try to get the medical community involved. And it's quite complicated because or they don't understand what we're trying to say, or maybe they don't see the value at this moment, or maybe it takes a little bit longer for them to get the relationship. So if really an organization like ATS can actually bring in the medical community together, start talking about these topics at our country level, that would be amazing. It takes a lot of time to actually get stakeholders convinced about environmental topics, and they do have impact on health. So if you could actually be an advocate for this topic, it would be great. I think that's an excellent first just to start, apart from all the capacity building and the tools and the resources and so on. But if we could do something communication, I think that would be the fastest way to go at this moment.
Great. What about you, Gabriel? What do you think?
Yeah, I totally agree. Advocacy should be at the center of what it should be at the center of trying to disseminate this information. And I think trying to involve as many stakeholders as possible, especially the people from the health community, would really be nice. And the translation of the information to the local context, in avoiding maybe just communicating the indices and leaving it there, how it actually affects someone locally. I think that will go way down into trying to send the message across, apart from just talking about AQI indices, etc.
Mm-hmm. How about George, from your perspective?
Yes, I agree totally that local, all politics are local, all policy is local. And, the thing is, I know in polls I've seen, the healthcare professionals and scientists are, even in this day and age, among the highest regarded people in our society, that they have credibility. So it's really important that every health professional and scientists speak out on these issues and get involved and just, get the science out there. That's it. That's the message. The science, share it. And as Gabriel was saying, the local level, you get a physician, it may not be an expert on air pollution, but he's knowledgeable or she's knowledgeable about the health effects of pollution, and they speak to the local community. So it really has to be bottom up in many ways, and we need everybody involved.
I'll just make a pitch that at ATS 2023 in DC, there are at least 5 different sessions teaching physicians how to be advocates, how to speak to the media, how to speak to patients using social media, etc. So this is definitely a skill that is not taught typically in medical training, but is critical. And as I mentioned, there's going to be quite a few sessions on how to do this effectively. I'm looking in the chat. There are a few questions, although let me see. Let's see. In light of climate change needs, what are the thoughts of how to realistically move countries towards the WH goals? George, I know you touched upon that very briefly. That reducing emissions will also help reduce reducing emissions for health will also reduce emissions for climate change.
Yep. The major sources that cause the health effects of the human health effects of air pollution are the same sources that cause the adverse climate effects. So they're really very closely aligned, and one supports the other. And I think it also translates. Sometimes it's hard to relate to climate change as a global issue, but the air pollution aspect brings it home to the individual level. One of the things I actually was hoping Kalpana might say a little more on was the satellite data, because what we heard was in these countries, it's very difficult to get data. I've tried to do research myself, and getting the air pollution data is a real challenge. But now there's satellites, and they can provide data everywhere in the world. Maybe Kalpana could take a second and talk about what's going on in India, because I think that's a way forward.
Indeed, I think I had one slide during my presentation. I mean, this has been a major breakthrough for us, because previously there was a lot of reluctance to use satellite data and to sort of, integrate them with the ambient air quality monitoring network, to sort of, get the gridded outputs, not just for, PM 2.5, but all the others that are relevant for climate as well. So there's capacities now to make this satellite data, much more accessible. In the regulatory agency portals, we are actually going to have gridded outputs from the satellite data retrieval, and that can be used for PM and NOx and anything else that we want to sort of really avail that for. So I think that would sort of really do that for both health and climate in one shot. And that is already what is nice is, in addition to the research community, the regulatory agencies have come on board to sort of, I think Stella alluded to, the modeling capacities of the country have increased such that we can actually have these model outputs available, so you can sort of, allow scenario building for various controls that can provide health and climate benefits, and look at how the outputs from the satellite models, change. So that would be the lowest cost data that we can actually access.
Gabriel, are you involved with the East African GeoHealth Hub? Because I know one major focus is sort of improved monitoring.
So I'm currently involved with the Makerere University Airport, the Makerere initiative that is making low-cost sensors in the country. And just mentioning satellite data, George, next week I'm receiving my first training on satellite data from Anna Prados and I think Brian. They're part of the NASA team that are trying to build capacity in satellite data in Uganda.
I mean, one question I also had the group was, there's clearly shared challenges. Are there opportunities also for collaboration, either it's training, or sharing methods, or sort of cross-training between different countries?
I think you just mentioned the GeoHub. So we actually just won one for Peru, and it's with Emory and Hopkins. So actually, that's a very good place to be. It's a nice initiative. We will have some capacity building that it's coming where we're training local Peruvians, but they're going to work with investigators from the north. So that's actually really, really good. And we're actually going to do exactly what you just asked, Gabriel, which is expand the monitoring network using low cost monitors across Peru, so that those 4 maps that you actually saw, there could be more green in those maps, right? So that is actually one of the best programs that we've actually have. It really gets in, it helps you also get involved with the local policymakers. For example, since we need the data from the Ministry of the Environment, from Senami, which is our meteorological service, we could actually offer one of those PhDs to one of those people, so they can actually also get trained in modeling and work with the scientists in Emory. So this is one of the things that we're going to do. So we build capacities not only for training in the research aspect, but also within the ministries and the people that in the end should uptake these programs and move them forward, no, and actually see the value of increasing this network and monitoring. So I can say that one of the things that the GeoHubs in the last iterations accomplished is that now Peru is actually, or wants to include these low-cost ground monitoring systems within their platform, even if they're not the best, even if they have their few things that maybe are not, no, but they still want to include them so that at least we can start telling the story. I think that's one of the biggest things, no? So, and I also think that that's because, and I also saw some numbers about mortality linked to ambient air pollution. It's because we really don't have the data, and we really don't know how if this is true or not. So right now we're in supposed. So I think that this type of programs where we can actually get capacity building from the north, that we can take students to the north, it actually helps. It helps us in the country as a country. Yeah.
Kalpana, I know you've also thought a lot about training as well. Do you have thoughts on this question? Is there opportunities for cross-pollination between different countries?
Oh, absolutely. I think, I'm not sure about the GeoHubs. There's a GeoHub in India that Public Health Foundation of India in New Delhi anchors, and they have a whole lot going on satellite-based modeling and stuff like that. But one of the things I wanted to propose was, if we could have some kind of curricular inputs into the ongoing MPH programs, for our program, for example, we have a track on occupational environmental health, but we are now thinking that, that's too broad right now to sort of really allow us to address air quality and health. So maybe we should sort of really look at, climate and health, and have the air quality and health module as part of the climate and health specialization, as opposed to, one of the NPH tracks we're sort of thinking of adding this year, or rather next academic year, it's too late for this year, is that, so if Stella and Gabriel and others and George and others who are helping support these UNL hubs can think of getting us, then it becomes a permanent feature. And these graduates, already would have received some of these trainings, and when they go and populate, various state departments or other kinds of capacities, they end up doing that. And these modules can be standalone, continuing medical education or continuing professional development programs that can be hosted also. So it can be modular in structure. So it would be fantastic to sort of come together. And I know WHO is already thinking also on sort of creating some of these capacity building modules. So maybe we can bring all these forces together to create this. But I think it would be very valuable to include them as part of an MPH curriculum as a specialized track, or leading up to a specialized track. But I also wanted to sort of quickly propose in a minute, it seemed like after listening to Gabriel and Stella, and of course George has done this for many years in the US setting, but at least in the low resource setting, is there something that we can try and do to bring some of these decision makers together from our countries, at a meeting or at where they listen to all these stories from each other. We often find, for example, at the ASIC meeting, I'm not sure if people are part of that, in Pasadena, we had this whole low-cost sensor network meeting where we had so many lessons learned. Our Indian policy decision maker came, but then I think he was looking for, it would be nice if we can bring a pool of these, technical attaches of these regulatory agencies and listen to each other, and WHO may be a great place to convene that because they do this thing, right? And then if ATS can sort of team up with WHO to bring these decision makers, not quite the ministers, the technical attaches of the different regulatory agencies, and just listen to these cross-country stories. Household air pollution is something that Peru is acting on, East Africa is acting on, and India is already acting on. So that kind of a theme, I think there's need to be, targeting these groups who are the most intractable in terms of sort of getting across. And we don't have enough critical mass of us in country to reach out to them. We need to join forces. What I personally think, our research, I'm not sure it's reaching any of their ears or any of their eyes in tangible ways. So it would be great to come together and sort of.
Yeah, I agree. And Kalpana has been involved in the past in setting these meetings up. I attended one in November of 2016, and that was wonderful. And maybe, I think taking Kalpana's idea and now taking what's happened in India and maybe globalizing it is a great idea. So I'm supportive. Go for it.
Great. Well, I can definitely bring this back to the ETS International Health Committee to see how we can kind of bring people together, especially from different countries, to talk about this really important topic. I realize we're now at 2:30 p.m. my time, and so it's probably quite late where Gabriel and Stella are. So I think we'll wrap this up, but thank you to all of our speakers, panelists, and our audience for listening in on this really important topic. As I mentioned, this is recorded, and so we'll send out the link to you so you can share it with colleagues, friends, and trainees. Thanks again, everyone, for joining on this important webinar today.
Thank you.
Thank you.
Thank
Bye.
you.